So welcome everyone. I know all of you, so I don't think I need to introduce myself.
All right.
Welcome to this speaker series, and I'm delighted to introduce Elizabeth Mansfield. Liz, and just in case you didn't know, on our new website you will see her bio there, but Liz is a scientist at the Institute of Better Health at Trillium Health Partners, as you know, whose current work focuses on patients and medically complex conditions, caregiver and healthcare provider experiences. She's a medical sociologist and qualitative researcher with expertise in meta-evaluation, discourse analysis, and program evaluation. A little bit more? Oh, okay. It's better now?
I'm just wondering whether it's worthwhile not using it.
I can just stand over here.
Yeah, okay, great.
There we go. Use my coaching voice instead. Okay. Her current work focuses upon service improvement for patients with physical and mental health challenges, experiencing co-design, population health, and to capture the diversity of needs and preferences. So welcome, Liz, and thanks so much for...
Thank you, Susan. It's great to be here today, and I'm very excited to be talking about a project that actually took place a few years ago, but as with all qualitative research, it takes a while to write things up and get them published. So the title is What Supports Are Needed for Clinicians When Implementing Pilot Projects in Primary Care Settings, and it very much draws from a paper and a wonderful team that I worked with when I was at Bridges, which included O'Neill Bhattacharya, Jennifer Christian, Dr. Gary Nagley, Dr. Vicki Stergiopoulos, and Fiona Webster. So it was this very interesting group of authors on this paper, but I would be sort of remiss not to mention some of the other folks that were often at the Bridges table. Dr. Lynn Wilson, Dr. Wendy Levison, and Dr. Jillian Hawkins as well. So anyways, this paper grew out of this work that I did at Bridges, which was my job before I came here. This Bridges was basically a university-based health services evaluation team. And it was very cool because they brought together expertise from primary care, geriatrics, psychiatry, and the social sciences. And it was a little bit of an embedded evaluation model. So what Bridges did is that we met weekly, and we would be reviewing sort of a suite of projects that were actually happening out in the community. And we helped to select those projects, and then we would also guide those projects in terms of helping them to figure out their evaluation approaches and then sort of steering them along. So it was a bit of what I would call an embedded evaluation approach. So the project that I'm going to be talking to you today is actually one of the projects that Bridges was asked to evaluate, and so I became very much the qualitative person involved in data collection and data analysis and sort of planning out this project. And so what the focus of this paper is to really think about pilot projects and to think about pilot projects in primary care and what some of the challenges are. So Canada, like the UK and the US and many other countries, has a long tradition of loving pilot projects. And in fact, some of my participants actually talked about pilotitis because there were just so many new initiatives going on. And some of them are absolutely fantastic. Some of them are terrible. But we have very, very poor knowledge translation strategies in place. So there's little evidence of converting successful initiatives into funded permanent programs. Very, very little sort of efforts have gone towards sharing project outcomes and insights. So we don't know, we often really don't know what else has gone on that's similar to what we're doing. And the other piece is that pilot projects, because they're often government funded, are often vulnerable to cancellation. So as with any government initiative, so this is just sort of part of the culture of working for governments, and it's not just our government, it's like any kind of government agency. This is one of the risks you run. And so as a result, and I mean, this has been known for a long time and was certainly a focus of Naylor's recent report on sort of how we need to be improving our healthcare system. And that is that while there have been many promising initiatives, few projects have been successful in terms of scale up and spread. So, one thing that I'd like to sort of step back from too, just very briefly before we go into the results from this study, is that I think there's real pros and cons to primary care using pilot projects as a reform. I mean, I think it's really important that we develop health services that are responsive to what's going on locally. And so these small projects do kind of give you a chance to look at different kinds of models. I also, of course, it makes sense that we try things on a smaller scale before we invest in them heavily and scale up and spread. So all of those things make sense. But as well, I think that primary care physicians, particularly based on the results from this study, they had like such an understanding of what was going on in their community. And so they were really good at sort of being able to kind of know what the lay of the land was and where there were opportunities to improve. So we have this sort of like local kind of grassroots movement, which in a way is what we do with pilot projects. And then, you know, we have sort of a centralized top-down decision-making structure. And so these are sort of the tensions that exist in kind of like, well, how should we do, why should we do pilot projects? So I think they do have merit for sure. So this particular initiative, this was the title of the grant, which was Demonstration Projects to Improve the Care of Medically Complex Patients. And of course, we proceeded to change everything to patients with medically complex conditions, to be politically correct. But this was the title. And because I think we're all medically complex. But so these were one-year projects, and it was an initiative that was funded by the ministry, and it was also funded by the OMA. So the OMA has a physicians service agreement where they have money that's available every year to fund some of their doctors who are interested in research. And so we were working very closely with the OMA all the way along to develop this, and it was a really interesting relationship. So in the end, there were 34 one-year projects that were funded. And then in 2015, we were invited to actually sort of be in charge of this evaluation. And it was very much you know, a qualitative evaluation. So when we actually look at the projects themselves, what did they look like? Well, they had a lot of commonalities. While there were different designs and approaches, all of these projects were focused on improving care, coordination, and management for these patients. Another common feature was that they were new models of service delivery, and they were intended to enhance interprofessional collaboration and partnerships with hospitals and community care services. So the whole idea was, okay, we've got this group of patients, they have a whole bunch of needs, let's see if we can develop different ways in different communities, get primary care more engaged in actually trying to innovate in this area. However, I think as I was reading the proposals, which was sort of my first role in this job, was that it was quite apparent that these were very complex interventions. What I mean by that is that they have multiple components. Many required administrative support, stakeholder buy-in, and several required technological platforms that would allow for record sharing and remote communications. So just thinking about that, you know, with our 1-year time frame. So I'm just going to mention a few more things. All of the projects had to choose between one of these categories. So discharge planning, community management, which was setting up, you know, clinics in the community that could help patients with medically complex conditions, and then hospital diversion, which is a way of trying to sort of minimize the number of patients that were coming to the emergency department because they didn't have other alternatives. So, and as I said, the project had many components. So as you can see, case management, healthcare coaches, nurse navigation, integrated care plans. I think if you look down the list, these are often the types of things that we'll see in this type of project. There were a couple of projects that had telemedicine components, virtual care conferencing, and then there were a few projects that were sort of looking at end-of-life issues that were quite interesting as well.
Did they learn from each other, or did they figure out these components by themselves, or did they kind of work together to figure out how?
No, these were all just this is just sort of, if we took all the components and threw them in and made a big soup, this is what you would see. So in other words, some projects might only have 2 or 3 of these, and some might have 6. But there was no, basically, Rob, they had, I think, about 2 weeks to put together this proposal. So it was just a group of doctors working independently all over the province. Yeah, but these are like popular sorts of things, right? Like nurse navigation. And so, but the other thing that was key to this, and the ministry was really pushing on, was that in this application, you actually had to talk about your collaborations and your partnerships. So the ministry is feeling, you know, at that time and continues to talk about the importance of integration, the importance of local partnerships. So how are you going to work with community and social services? How are you going to work with healthcare organizations? Because of this population group, patients with medically complex conditions, there are and there was in this particular suite of proposals a lot of different projects that were trying to sort of target more support for mental health and addiction services, and as well home care agencies, especially for the frail elderly. So then we come in, Bridges, and we do the MCP evaluation. And like Bridges, I think, I mean, I learned so much being there. I mean, just as I do learning here, but I mean, that's all sort of part of the joy of doing this work, I guess. But we really did want to feel that we were sort of going to be doing something akin to rapid cycle evaluation, being able to feed back every few months or so, kind of like what some of our big picture insights were for these teams. And so that was going to sort of help these projects, as you can see, course adjust. And so that was the dream. And it was really so, this was the best point in time. So we had this beautiful design. You know, we had the ministry, the OMA, and they were so on board with giving us the resources we needed to do an evaluation properly. So, you know, we're basically looking at the strengths and challenges just from sort of the primary care physician perspective, because we couldn't do it all. And quite frankly, if you're going across a province and you're trying to do it all, you're going to be dealing with every research ethics board if you start bringing in patients. So we just thought, we'll go here. So semi-structured interviews with primary care physician leads at 2 points in time. And then ethnographic case studies with 4 to 6 projects, and that was going to include site visits and project team interviews, so in addition to the physicians. So what was this going to do? It was going to allow us to really understand the projects and why they work under what conditions. So again, you can see where my interest in realist evaluation comes from. Very, very Bridges informed. And then there was going to be this synthesis of our data, sort of this longitudinal picture on 6 months, 12 months for these physicians, and this case study data integration. Well, it didn't happen. Because you know what happened? Remember how I was saying pilot projects can lose their funding? So can evaluation teams. We actually only had one round of interviews. Fortunately, we had a very good response rate, so we got 34 interviews. We didn't get a chance to do the case study, and we didn't get a chance to go back again. So very basically, we were using a bit of a meta approach. That was quite terrific. So we designed our interview guide for all of these physicians, no matter what type of project they were in, that we could get them talking about their interventions, and that we could then, start that as a basis for a common code book and things like that. So the data collection, we did a little bit of a proposal review. So I started out with a huge inventory, trying just to figure out how all of these proposals might fit together, but it was a useful exercise. And then I began madly recruiting and interviewing primary care physicians, I would say about 3 to 6 months into when they had started their intervention. And there was a little bit of variability because some of these projects really never got fully launched, so it was kind of touch and go. But I had an amazing group of participants. I felt they were very candid. We did some of the interviews in person in the Greater Toronto area, but for purposes of study feasibility, we did telephone interviews, but those were also excellent. And then we just did, basically, we collected all this data, we had it transcribed, and then the team worked together to come up with the code book, and we coded the data. And then we focused on writing it up. So I'm just going to talk very briefly about the sample. As you can see, it was more males. I do think that, and we also had very few really new doctors. And most of the projects were set in city or urban environments. We had 4 projects that were rural, sort of small town type pieces. And then most of our docs did have quite a bit of experience as well, working in their communities. So thinking back to what I wanted to discuss today, which is really what is it like if you're a primary care physician, you're working in this busy practice, and you're now taking on a project. And so that's what we were trying to get at. And what we found was that there were some very strong themes. And first of all, it was really quite incredible to talk to some of these docs, because they truly were advocates for change. And they understood the system, they understood where things were wrong, and they were tireless advocates before this project, and I'm sure after this project, for their patients and for system change. And then what they found, and for some of the docs, this was their first kind of wading into the water of doing a pilot project, but they found that there was reluctance to engage with pilot initiatives. And they also found that it was difficult to create partnerships and leverage support because, as I said, there's pilotitis. There's a lot of projects out there, And so whether you're in a hospital or whether you're in a community care setting, there's a lot going on. And I think the final area where they were really candid with me was in talking about navigating the tensions between clinical and project roles. So I'm just going to present some of the findings. So as I said, people really did advocate. And I'd like to just turn your attention to the second quote, because I thought this was so interesting. We had a lot of folks who were actually working in communities where there were very specific needs. Some were working in the area of mental health, some were working in northern communities, some were working with immigrant populations, refugee populations. So this guy, participant says, as someone on the front line who sees these individuals, I think you become an advocate for either small changes on an individual level or large-scale changes, and changes at a systems-wide level. I think there's a role for advocacy within the healthcare system, as well as to look at utilization of dollars and to try and advocate for more prevention, more focused practices to help minimize more costly outcomes. And then if you look at the first quote, you can see like how well these patients also, or these doctors, I should say, know their patients and their family circumstances. So, for example, some of these interventions allowed doctors to make home visits or to have a clinician in their practice make home visits. And the other piece that was really interesting in interviewing these doctors was that quite a few of them had been practicing for a while. And so what they had seen was they'd seen the complexity getting, as this person says, I've seen the complexity getting higher and higher, and the stays in acute care getting shorter, and the burden of care for primary care physicians getting very high. Older patients, very complex patients, just really not getting optimal care because our system has become so siloed, and one silo doesn't speak to another. It just becomes so fragmented that you think there's got to be a better way to do this. So I think that a number of participants were really a little bit disappointed that they weren't sort of taken up to the same extent that they had sort of in the original vision, and I think we've all been here. But in some cases, like for example, local hospital departments were not receptive to pilot projects. And even when this particular intervention was there to help to reduce the overuse of costly hospital services. And so this physician noted and said, the principle is if you are diverting the flow of patients and removing the role of the emergency department from being responsible for pre-hospital care, well, that is encroaching on people's turf. From a systems point of view, to reduce the flow of patients to the emergency department is a very positive thing. And I think from the point of view of a lot of emergency departments, that would be seen as a positive thing. But you get resistance from people. Whenever you're changing well-established ways of doing things, it generates resistance. So I thought that was really, really interesting because I think what this participant was pointing out was that even when you have part of an organization that sees how important a change is, you still have people that are entrenched in their ways of doing things. And so change is difficult. So, and then secondly, there was also healthcare provider buy-in resistance with pilot projects. And I think, again, this is happens a lot of the time, is that project teams that I've been involved with learn that you have to be very clear about your messaging. Let's say you have an intervention where you're providing support for 8 to 12 weeks after discharge, and you want to sort of help get that patient up to speed, but you're not taking that patient from an existing practice. You have to be very, very clear and detailed about this. So this first participant says, we had to be very clear from the beginning that this was not a takeover model. And then the second participant also noted that there was always, and this is, from a community, says there's always this small group of physicians who just don't want to do anything outside of their scope of work. And they're very busy, but they're just not interested in anything that is like non-clinical or a reform project or whatever. So they were finding resistance because these projects required not only patient recruitment, but physician recruitment, because you had to recruit the patients through physicians. And the third quote is interesting because this doc was setting up a service for patients that had very, very severe mental health and addictions issues. So his idea was, okay, I'm going to give these doctors extra funding. So there's financial incentive for them to get involved in this project. There was very little interest, so he was quite surprised by that. So as he says, improved funding is just not sufficient to get physicians interested in looking after these subsets of patients that are a very difficult patient group to work with. So the other piece that I've alluded to is the fact that, okay, you're in a very competitive project environment. And it's hard for us, right? Because whenever we're developing projects, it's just, this is the best thing ever. And then you get out there and you realize there's also people singing the same song. And so some of the, because these projects were done so quickly, they really hadn't done kind of a needs assessment or kind of a lay of the land or any kind of analysis of everything that was going on. So in this case, the first quote was this guy was talking about, so we have no idea what the other groups are doing. And we end up with some of the same toolkit or a slight variation of the same toolkit kind of down the road. So we have 60 toolkits that are all kind of the same because there's so many initiatives. So, and certainly like this continues to be a problem. Like I would say, projects really, I don't want to use brand, but projects have to be so clear to be able to understand what else is going on and how their service is different. Like what do you offer that this project that is similar seems to offer? And then the other piece was that because there's so much going on, as the second person said, and they have multiple competing projects going on at the same time, so why would they make our little idea the #1 priority? So this person was talking about going into organizations with a really cool intervention, and they're saying, well, no, we're already doing 6 things for the next 2 years. Why, how can we do this too? And I think the other piece that was really interesting to me was that we did discuss partnerships and support. And one of the participants I remember quite clearly speaking about, well, there's support and there's support. And so in this first quote, this doctor noted, but when you map out your stakeholders, some people are really actively engaged champions versus just, oh, I'm going to help by sending out an email, like once every 4 months. So that was sort of, so she was talking about how, it's not just the person, but are they really committed? So, and another piece was just not feeling that their project was a priority. So, as I mentioned, most a couple of years to mature. I mean, I think that's realistic. I still don't understand for many projects the 1-year timeline. It takes you like several months to get things going. So I'm just going to go on to my last theme, which is navigating the tensions between clinical and project roles. Because I think this is really the area where here at IBH we can play an important role. I think these participants were so candid about what they could do and what they couldn't do. Like they had they first says, like, I wanted a mentor, almost a research mentor, who can check in with us and say, oh, you said you were going to measure this. That hasn't been happening. Why is that? So, you know, give us some help. And then specifically needing research. Asking, like, how do we get this going and how do we overcome those barriers? How do we deal specifically with healthcare legislation for privacy and information transfer? Like, these are huge issues that these projects had to deal with. And then finally, you know, people are really, really busy. So one thing that was very, very apparent was that we had lots of solo docs, and they were not in a good position to do these projects. Because these projects, I mean, they did them, and some of them were very successful. But with these projects, you were expected to build a team. So if you have a family health team, you've already got an infrastructure in place. If you're going in for a solo doc now, he's got to figure out, or she's got to figure out, how am I going to hire these people? How am I going to set up my, you know, sort of human resources for this project? It becomes really, really complicated. And I'll just go down to the final quote there. I think the projects that are being led, say, by family health teams, they wouldn't have those kind of challenges because they're already established as a team. So it is a challenge for fee-for-service clinicians to create a multi-service team. And so, you know, there were huge differences in terms of whether or not you had protected time. So, as I mentioned, our study design was limited in terms of it would have been great to have all of the things that were on our wish list. And it's true that some of the participants may have felt pressured to present positive findings, but I think that people were fairly candid. But, you know, there's always that risk. It would have been great to have other folks on the project teams other than the primary care physicians. So going forward, we would recommend that. We would recommend our original design. And finally, I think that because as a group, we were all so engaged in implementation science, we may have seen everything in terms of implementation science. So there may have been a bit of bias on our part. So just to sum up here, I think that the primary care physicians were incredibly dedicated, but faced systemic challenges all the way through. Whether in designing and planning their interventions, they had not anticipated these challenges. They encountered concerns about taking over other people's practices, services, which was not the intention, but nevertheless, I mean, that's hard to deal with. Many of them were solo docs, and so clinical care responsibilities for patients had to take precedence, and so their projects could end up getting delayed. And then as well, they all talked about feeling that they had some expertise that was great in some areas, but they needed help in others. And practice arrangements made a difference as well. So finally, just going back to the title of this talk, what supports are needed? Well, I think we have to begin from the whole idea that we have to start at a systems level and really think about like what all these factors are, like practice arrangements, like protected time, like the availability of research support. How do they affect clinicians' capacity to lead, implement, and evaluate improvement interventions? In the UK, when they rolled out a similar pilot care initiative, they had a traveling evaluation team. And that evaluation team was constantly in circulation, going out to these, I don't know, I think it was 14 pilot projects all over the UK, and helping them. That's all they did, was they were helping them land on the right metrics, helping them sort of set up capacity to do qualitative research when they weren't getting the outcome measures that they wanted quickly. Thirdly, peer review of project proposals would be like just so amazing, especially if some of those reviewers had subject matter expertise. So, you know, I don't think this is any secret. Like there, you know, sometimes there are great projects out there and you say, wow, this project really is meant to be. But then there's other projects that we look at and we're kind of going. So we do need to have, I do think we do need to figure that out. Realistic timelines. 1 year for a pilot project intervention that's going to involve information sharing across organizations, that's going to involve a staff of 5 that's right now just a solo practitioner. That is not going to happen in a year. There's training that needs to be engaged in. That's not going to happen in a year. Effective communications. You know, I found this to be true of every single pilot project that I've looked at. You know, for example, I'll just give you one short example. Integrated care plans. There are so many different initiatives that have integrated care plans that you'll call up a doctor and say, well, we have an integrated care plan. And the guy will say, well, I already have 6 of those. What's yours like? You know, so you've got to really, really market yourself carefully. And you've got to be very clear. And the other piece that didn't come through in this data, but has come up since then, is that there are other reasons why primary care physicians are reluctant to engage with pilot projects. What happens when the pilot project ends? And I mean, so you've given somebody now this really cool service. Now you're going to have to go back and say, sorry, patient, we're back to the same old stuff as we were a year ago. So that's tough. And then the other part is that I think that doctors and communities get sort of tired of seeing projects pop up and, you know, what's that game? I don't know, guacamole or whatever. But it's sort of that kind of, these projects are there. It's like pop-up shops, you know. So you're reluctant to send your patients to something that you don't know how long it's going to be there for. That being said, I mean, Monique Begin was talking in 2009 about how there should be pilot project repositories. We don't have them. We have, well, but I mean, it just makes so much sense. Wouldn't it be great if you had an idea for a pilot project and you could go and look and see what other people had done? Like, I mean, that just is common sense, you know? I mean, and I don't think that that would be like a huge, impossible thing to do. And then, so, and we could look at design, we could look at implementation, we could look at evaluation learnings. You know, in the right environment, I think people will be very open to even like sharing data collection tools and things like that. Like a lot of things that new project teams find themselves not doing well and they feel badly about, there's no reason for that. And then finally, I think that that there's tremendous strengths in pilot projects as a primary care reform strategy, but without the proper supports and resources, it's unlikely to produce sustainable and scalable health services improvements by intention. So that's it.
Thank you very much, Liz. And all of that should be in the next year's provincial budget, right? And initiatives and evaluations, right? So we have time for a few questions. Anybody?
So you did mention that like there should be a peer review process. What was the actual process? Because I think I might have missed that at the beginning.
Well, there was like the proposals were reviewed and selected, but to have a proper peer review process, they would have been blinded, and you know, you would have brought in some content expertise. And I do believe that the ministry is doing that now. So I think that, you know, the ministry is actually, you know, like, things are changing. Yeah.
Well, I think there's some interesting models of peer review. One that my former boss advocated was one more of merit review, where you do bring those content experts, which are either the decision makers, the patients, or the clinicians involved,
Yeah.
so that actually can make sense of what's being there. So it's peers amongst who the project affects, as well as the
Yeah.
peer researchers. Yeah.
Yeah, and I think, for example, like the most recent call of the ministry, they are using patient reviewers.
Right.
So absolutely, they have changed. So that is good news.
Other question I had was, one of your quotes was from a solo or fee-for-service provider who's basically saying, I need other resources to help keep me on track. And this might be a two-parter, but did you find from family health teams that they felt more resourced, or they still felt they needed additional resources?
They felt more resourced. In fact, I have one family health team doctor who was also very closely involved with the hospital. And she just said to me at one point, I don't know how solo practitioners could possibly do this. Because, I mean, even cashing a check, if you're a solo practitioner, is like, you've got to set, you know, you've got to, I mean, it's just very, very complicated because you're in private practice, right? So yeah, so they did feel really, really like the family health teams were in a much better position. Family health organizations, oh my gosh, I talked to that person for a couple of hours. I mean, because he really had, I mean, he did a whole bunch of such cool stuff, but he, like, and he said during the interview, you know, like, this is the ideal position.
And were they salaried or fee for service?
Salaried.
Yeah.
Yeah.
It's lost income.
Yeah.
Doing that.
Yeah, exactly.
And then do you think with med schools having that quality improvement, or like, I think residency programs now require their, I don't know, what do you call them, residents, to do a QI project? Do you think that helps to arm them with the skills they need to do some of that?
Or does it create more problems?
Yeah, or does it, or is it just like, is it just making them feel like they're experts, and then when they get into it, they're like, I need someone now?
Yeah, that's a really, I mean, that's such an interesting question. Be an interesting study too, we might add. But, you know, I think that maybe it helps a little bit, but I'm not sure like what it's like when you're at that point in your medical career. Like, I think you're taking on so much clinically. Sort of the exciting part. Like, I don't know, like every time I've had like sort of been in those sort of research teaching modes with medical students, I'm not sure how much they're picking up on. And it was interesting in our sample, the people that came to research, that were interested now in research, were just so sick of the system not working that they had taken this on.
Yeah.
You mentioned on the communication, like doing your homework to know what's needed, but because there is a repository and because knowledge translation either often doesn't happen because the pilot doesn't get funded and no one has the money to write, or it takes 2 to 3 years for a journal or a book to come out. How do you do your research? How do you do research if there's no base place to do your environmental scan of what's out there, and you don't have the money yet to do engagement on the ground because you're just getting, and you only have a year, so your engagement could take months, and then you're 6 months into your, like, how do you do that homework?
Well, I mean, I think that's a great question, and I think part of that is set up how these calls come forward. Like, I think that they're, like, first of all, you'd have to have these things already in place. But, I mean, when I talked, my participants told me that they basically had about 2 weeks to put these proposals together for this particular competition. So I think you have to have timelines. And I also think that you have to have infrastructure support in place. Like, you have to have people that can be mentoring. Like, I think that there is a real role for clinicians to do this research. They had some great ideas, but they need support. And we don't provide them with supports. And that's really, really, I mean, that's our failing, I think.
I a traveling van idea.
Yeah.
Any other questions? I just had a couple, but okay. So when was I lost a bit of track of how many projects were there?
There were 34.
Okay.
One didn't launch, but the story of not launching was really interesting. And then one project I had, there were actually 33 projects, so 33. So I got all 33 physician leads.
That's my question. Yeah, that's great.
And then one project had 2 leads, and they wanted me, and one was, you know, up north, and one was more local. So I spoke to both of them.
And then what is or was or might be the plan to communicate this?
Oh, I should tell you that. Like, well, you know, Bridges, unfortunately, we lost our funding. I mean, I came here as a result, so I guess that's the you know, sort of the happy story. But we actually ran collaboratives for all of these clinician leaders. So we had 3 major collaboratives and an end of project conference, and it was amazing. And it wasn't just for the clinicians, it was for the entire project teams. And so we did we looked at different kinds of, like, finding the right outcome variables. We did one on training your staff up, and like really cool stuff. And so I think that was our dream, was that we were going to be able to carry on this collaborative structure and help projects. But unfortunately, as so often happens, directions change.
But is there a feedback loop back to the ministry?
They got a report.
Okay, right.
Yeah.
And they'll get their if there's anybody in the ministry there, you can send them.
Well, and it changes so much.
Yeah.
Judith.
Why they didn't want to continue? Was it just more the political wind blew the other way?
The political wind blew the other way.
And it's coming.
Yeah, you know, it's interesting because, I mean, one of the great things about Bridges was that I got to meet so many interesting people that were working in different areas of health. And one person just said, oh yeah, this is about the 5th time this has happened to me. So it's, you know, it does happen. It's not a
particular learner, like something that you've learned that we can kind of do to make that better?
I think, Judith, it's interesting. That's a great question. I mean, I think the things that I've learned is that, well, first of all, I love implementation science, so I'm always looking at projects through this lens. So I feel tremendously lucky to have had this education. I think that the big learnings are really just to plan, be careful, move slowly, make sure you have the right supports in place.
Don't spend all your money up front.
Don't spend all your money up front, but do spend money on evaluation. And the ministry even had a limit on how much could be spent on evaluation, right? So that was a problem.
I think something that we've learned from IBH is that it's never too early to think about sustainability. And like things you say too, like, yeah, what if the funding goes, what's now left of the project?
Well, I mean, that's so true. But a lot of these projects wouldn't have been, I mean, I would love to write a paper on, called After the Pilot Project.
I know, that's true.
Yeah.
About sustainability, you have to think about it front, right? In terms of, okay, how do you make it into the operational budget? And so how do you create the process actually work in their workflow so that it's
Yeah.
easy to uptake and it's not like injections of funds every single time.
Yeah,
Exactly.
It's so great if it works, they will do it.
Yeah, that's a great point. That's a great point.
I think it actually should be part of the peer review, in fact, and
Yeah.
call for applications, because for me, there's a big ethical dilemma of offering things to patients that you then withdraw.
Yeah.
And I think it's really unfair and
I think it is too, and I actually had a bit of data from that, you know, and so that paper might be called like Difficult Conversations.
necessary conversations with the ministry. Yeah, that's right.
Yeah, it was really, I mean, yeah, it is really sad. Like, especially like with really elderly patients. Imagine like finally having your doc visit you at home and this is your last home visit, you know? Yeah, it's tough.
It's really not nice. Any final comments, Liz? Thank you so much. Is there anything else you wanted to say?
No, thank you very much. Thanks.
Great story. Thanks, everybody. Our next one is in May officially, but we might be able to rejig something for April. We're in the works of figuring that out, so stay tuned. Great, thanks. Okay.
Yep.